Thank you, Greg. And thank you to Julio for inviting me to talk about the cascade of care. I'm going to go at Mike Cohen speed so I can get through in my 15 allotted minutes. So I'll be speaking a bit quickly, I think. I think we're all familiar with many public health programs involving a cascade of interventions, and I think we've seen that the attrition rates at each of the steps are multiplied and so result in potentially low overall rates of coverage and impact. And this, I think most of us are familiar with the PMTCT example. I apologize if we've been, I think, all week, or at least a few days, used to looking at these bars vertically. So you're welcome to sort of lay your head down to the right if you need to get oriented, and I won't think you're asleep. But in this example, if 90% of HIV-infected pregnant women attend ANC, and 90% of them are tested, and 80% of them receive antiretrovirals, and 70% of their infants receive antiretrovirals, these are actually multiplied, and so the coverage of the full package would be only 45% in that example. We've also seen many times, including just in John O'Merman's presentation, the US Cascade, and it's a similar sort of dynamic. There's actually, I hear a few different references of a few different groups that have looked at this, but we see the cascade there, and then I'm using the leaky pipe analogy, which I think I first heard from Carlos Del Rio, and we end up with only about 20 to 30% of people with HIV in the US having an undetectable viral load, unless they're in San Francisco, and then it's 47%. Where they're doing a bit better. And so this is just the same cascade that we've seen several times in highlighting that 28% that have a suppressed viral load of the entire denominator being the entire population of people with HIV infection. And so I've tried in this presentation to then take this to a sort of a global overview, focusing on sub-Saharan Africa, and emphasizing some meta-analyses and systematic reviews that have been done. And so starting with HIV testing, this is from the recent WHO Global HIV/AIDS Response Progress Report, and highlighting a few countries where there have been serial population-based surveys, demographic health surveys. And let me just highlight Kenya, where in 2003, only about 20% of people had ever been HIV tested. By 2008, that was up to 73% of women and 58%, 59% of men. And so it actually, I think we've been sort of fretting about the HPTN 043 and only achieving, in the context of a clinical trial, 40 or 50% coverage. Here on a national basis in Kenya, they're well over 50% of people who've ever been tested. However, I want to make an important caveat. This is from the Kenya AIDS Indicator Survey, a nationally representative survey, and we could see at this point in 2007, many Kenyans had been tested. 41% of women and 25% of men had ever had an HIV test. However, of people in that survey who were identified, who were tested HIV positive, only 16% of them were aware of their infection. And 28% of all people with HIV reported that they had their last HIV test was negative. So I really want to highlight that coverage of testing is not the same as identifying people with HIV. And I was actually very gratified to hear in China that they're really embracing that focus on diagnosing with people with HIV, not testing everybody, anyone and everyone. So moving on from testing to the next critical step of the cascade, retention in HIV care. And in this systematic review looked at what in some contexts we call linkage, basically getting from diagnosis to initiating ART. And these authors separated it into 3 stages. Stage 1 being from diagnosis to either getting a CD4 count or clinical staging, and the retention for that one stage was 59%. Stage 2, getting from that staging to ART, determination of ART eligibility, only 46% retention in that step. In stage 3, from ART eligibility to actual ART initiation, only 68% retention in that step. They note as a significant limitation none of these 28 studies followed a cohort all the way from diagnosis through to initiation. So these can't really be multiplied as we do in some other examples. But they did say, highlight that of those who are not yet eligible for ART, less than a third of those people are retained. Based on looking at these studies, they concluded that less than a third of those people are actually retained through to the time that they initiate ART if they're not initially eligible. The same authors, in a different study, different systematic review, then turning from that more linkage-related issue to the retention issue, showed with 33 sources, 39 cohorts, most attrition was due to loss to follow-up, followed by death as the second leading cause of attrition. And so they found 76% retention at 24 months, and then when they adjusted in a sensitivity analysis, that was about 70% retention at 24 months, which these aren't shocking numbers for us to see. In the more recent WHO and UNAIDS reports, they have a somewhat more optimistic findings from reported national surveys or national reports, and so their 24% follow-up is in the 70 to 90% range, but even in some countries by 48 months, we're down to about 60% retention. So clearly also an issue in the developing world setting or low resource settings. So this, I made this figure, but the data comes from this same WHO progress report showing by region rates of ART coverage, and then I basically used the same numerator from that report with the denominator of all people with HIV from the same data sources. And so we can see overall we're at about 47% coverage of people with CD4 counts less than 350 in low and middle income countries. But when you look at universal coverage, so-called universal coverage that we've been talking about, it's down in the 20 to 25% range. So the glass is either 1/2 full or 1/4 full, and this just looks at some select sub-Saharan African countries and highlighting some of the differences. Botswana with 93% coverage on the one hand, Nigeria with quite lower coverage on the other hand, and then also highlighting that if you're talking about everybody, you're only about half of where you were if you're just focusing on those with CD4 counts less than 350. Another key message is that the glass is maybe only 1/2 full or 1/4 full, but it's actually rapidly filling up. So when I think we're talking about 2- and 3-year-old data and bemoaning how little we've done or how much further we have to go, there's impressive progress being made. And so this is showing, and this is only through 2010, and we're now in 2012, how quickly things are going and continue to go. In Zimbabwe, for example, there's about estimated 5,000 new infections per month, and about 8,000 people being put on treatment per month. So progress is being made. Moving right along, adherence is not something that we put in the foreground in a cascade, but it's critically related to the viral suppression aspect. And so 2 studies, briefly, one, a meta-analysis of 31 studies and highlighted the differences in the North American studies. The adherence rate was about 55%, and in the African studies, the adherence rate was 77%, so significantly better in sub-Saharan Africa. And another meta-analysis, this time with 84 studies, they report globally that the adherence is only about 62%, but also highlighted that there's better adherence in countries, in resource-poor countries, or countries with a lower human development index. And then lastly, in the Cascade, perhaps the holy grail of virological suppression. And this was a systematic review looking in programmatic settings, non-research settings, 89 studies, and in this review, published in 2010, identified that after 12 months, 76% of the patients were suppressed. However, I want to highlight that they were using a cutoff of less than 1,000. And so when we talk about 77% suppressed in the US setting, that's using a cutoff of 200. So it does not look quite as good in the global setting, actually. This, I want to also emphasize limitations of doing this kind of a global overview. There's very different data collection and analysis methods, so it's quite limited to make inter-country or inter-regional comparisons. I'm not going to try to put together the global cascade, given the heterogeneity of the data sources and data quality. And then secondly, as I've mentioned, that the published data lag behind the intervention successes. So we're looking at meta-analyses done in 2008 from data from 2006 and earlier, and here we are in 2012 where a lot more progress has been made. So to summarize in this overview of the cascade in Africa and other low and middle income countries, testing and diagnosis are lower than the 80% diagnosed that we quote in the United States, but it is rapidly expanding. And I do want to emphasize again that the percentage of people living with HIV diagnosed is not monitored and lags significantly behind the proportions of people who have been tested. Linkage and retention, as in the US, there's substantial attrition in both linkage and retention. Treatment coverage, as I've said, is substantially lower than in the US, but rapidly expanding. And again, by region, in the low and middle income countries, the overall coverage, the coverage of those with lower CD4 counts is 40 to 65%, and among all people with HIV, about 20 to 30%. Adherence is suboptimal, but is better than in resource-rich settings or North America. And virological suppression is incomplete on first line. That study that I did show was of those who were starting on first line, and then with limited laboratory monitoring and limited availability of second and third line drugs is a significant challenge. So overall, it is safe to say that with only 20 to 30% of all people living with HIV on ART, and not all of them virologically suppressed, the overall virological suppression, unsurprisingly, seems quite lower in low and middle income countries than in the US, for example, where it is already fairly low. So in my CDC role, I can't make recommendations without a lot of clearance and things you don't want to hear about, but I can have a slide about programmatic considerations. So I would say, I think it's helpful to say that one should know one's cascade, as we say, know your epidemic. And we do need more robust and standardized monitoring at each step, from facility levels up to global levels of where we are with our populations of people with HIV in those settings. And again, I think it's important to monitor the proportion of persons diagnosed and not the proportions of persons tested, which is what's currently the standard practice. So that can be done with the periodic surveys that include HIV testing or case reporting system, as we use in the US, or in actually Vietnam is also using this among other countries. And then lastly, and this is something I've mentioned from the floor a couple of times, with the substantial attrition, interventions are needed at each step. Those interventions exist, and I'm happy to be followed by and not following Melanie Thompson, who's going to go through some of those critical interventions, especially for adherence in their guidelines. But I would say, to maximize the treatment as prevention aspect, all of these interventions really should focus on those most at risk for transmission. And so maybe in response to Joop, I would say we should try to provide everybody with a parachute, but not everyone needs a parachute at 10,000 feet. Some of them can wait until they're down to 3,500 feet, to pick a number. But for people that are transmitting, we could give them parachutes at higher altitudes. So let me thank you and leave you with this image from the workshop website of this beautiful city. Thanks.